Good morning, everybody. Right, can I have everyone's attention, please? Okay, we're going to start this Ignite session shortly. And, sorry, my name is Ula Chetty, and I'm a GP from the UK. And this morning we have 5 short, snappy, interesting presentations, varying in all sorts of topics, from HIV PrEP to some interesting projects, and one titled, Through the Mouth Dies a Fish. So we have some interesting presentations to listen to. What will happen is that they'll occur over 5 minutes, and then, so everybody is going to present one after the other, and then there will be opportunities for questions. So please, please, do think about some interesting questions as the presentations go along so that we can have some dynamic discussion at the end. HIV PrEP. So just one moment while we get organized. So for me, I just started.
Yeah, so the presenter needs to come up. Yep. Okay, so, and then,
it
once it starts here, it will go automatically.
Okay, so I'd like to call up Carla Rodrigues, who's going to talk about HIV pre-exposure prophylaxis.
Different PowerPoints, okay, so once they click, they start rolling.
Okay, that's fine.
So each one is one separate PowerPoint,
okay?
Good morning. So I'll speak very fast, and I'll try not to step on these words. They are very hard. So my name is Carla. I'm the coordinator of the National Sexuality Studies Group of the Family Practitioners Association. And I work with sexual issues mostly. Will this pass, or should I pass it? Okay, so in this slide you can see the names of the rest of our group. They couldn't be here today, but they all contributed to this work. So what do you know about pre-exposure prophylaxis for HIV? It's not passing. I don't think this is passing. It goes automatically every 20 seconds. 20 or 50? Because it's 1 minute here already and it didn't pass. Okay, then you should move on. But I will have to move the slides otherwise. Okay. So how can we stop HIV? HIV is a huge disease that's killing a lot of patients. We are estimated to have 36.9 million patients living with HIV worldwide. And we estimate that the new infections are 1.4 million. How do we stop HIV? First, the entry point is to diagnose it. Okay, that's the first step. And what's the state of art in eliminating HIV? So we have the risk behavior prevention by counseling. We have structural interventions with our own governments. We have the STI treatment because, as you know, syphilis can help the infection of HIV. We have male circumcision. We have non-antiretroviral vaginal microbicides. And we have, of course, the advent of therapy in HIV, antiretroviral therapy. So what's PrEP? PrEP, it's a pill you give to people so that they don't contract HIV or that their odds of contracting HIV are lower. PrEP is already available in some countries in Europe, and as you see, France, Norway, Belgium, Scotland, and just a few months ago, Portugal, happily. And a great study is the Be Prepared study that is showing how this is working for Belgium. The formal indications for PrEP are different, but as you can see, it has specific indications for men who have sex with men, and then for heterosexual couples, and then for people who have used injectable drugs. But as family practitioners, we manage the primary care, we have a person-centered approach, we have an holistic model, a community care, and an extended approach in specific problem-solving skills. So should we prescribe PrEP? Well, we actually are the ones who deal with seronegative patients. We deal the ones that don't have HIV. The ones that have HIV are sent to hospital centers, right? And of course, we are more professionals. We have a lot more GPs than infectiologists, sorry. And we have a privileged access to seronegative populations. So why shouldn't we prescribe PrEP? The real world obstacles are, of course, logistical, because we have time restraints in consultation, and financial, because we need someone to endorse the drug. We have real world obstacles that are mostly our attitudes towards PrEP. Even though they can relate to technical skills, we don't know how to use PrEP, or moral and ethical skills, attitudes. Because sometimes we can not agree with giving a pill for someone to have risky behaviors and then not contract HIV from it. We have a purview paradox. So we know that even though primary care is the type of doctors that deal with seronegative patients, these doctors are less willing to prescribe PrEP. But if you think of infectious disease specialists, they are experienced with antiretroviral therapy, but they don't face seronegative patients. So we have a problem here. We are not addressing a whole lot of patients at risk that should be prevented from the infection. Which strategies can we use? We can recommend the implementation in each country, and fortunately my country just took that step a couple of months ago, but it's not the GPs prescribing. We just assess the risk and then send the patient to the hospital so that they can get PrEP. And PrEP actually is a drug that's an antiretroviral pill that you give to people infected with HIV. Just the difference is that you give it to them before they get infected. Which candidates should be taking PrEP? We should make a careful assessment, and of course our willingness to prescribe changes with each patient. Also, our doubts and fears regarding the safety and efficacy of PrEP are a lot, so we should all take some time and read some information about PrEP. PrEP is safe and it prevents at least 86% of HIV infections. Okay? We should think that HIV is a lifelong disease without cure. Of course, there's issues with resistance of antiretroviral therapy, and we should consider it. How? Because sometimes patients are in seroconversion period. Patients are already infected, but not showing signs on blood. So we should assess HIV presence first, give it some time for seroconversion, and if the patient remains seronegative, then give the pill so that we don't create resistance. Then, of course, the toxicity, but we know the toxicity is very low. We have a startup syndrome, and we have some decrease on bone density, but it's all reversible, and the renal function should be assessed. That's simple enough for us GPs, right? And, of course, the greatest fear is of sexual inhibition of people taking PrEP. The thing is, the studies didn't prove this one. So if a person doesn't use condoms before, they won't use it after PrEP. But if you find someone that actually takes some serious concerns, it won't increase his risk behaviors. He won't stop using a condom just because he's having PrEP, okay? So we are not actually telling people to go on and taking risk behaviors. We're just helping them to not get infected. The recommendations for implementation are simple, and we just need to advise them carefully and insist a bit on therapeutical compliance, because it's a bit different. For example, you can give PrEP just before a risk behavior, just like one pill and one pill after. But for example, for women, because of the pharmacodynamics of HIV, women need to take a pill daily. Otherwise, the mucosa of the vagina won't have enough defenses. So we should be trained in these approaches, and we should talk to our patients carefully about this. Should we be the generation to stop HIV? I think so.
So I'm just going to get the other presentation loaded up, so bear with me one moment.
It's not necessary.
Yeah? Okay. In that case, can I invite up João Alves, please? Through the mouth, dies the fish.
The moment you say start, he will click and it will start rolling.
Okay.
Okay? So he's uploading. You just have to say start.
Okay. Hi there. My name is. Can I start? Good morning. My name is João, and sorry for my English, and I'm a little nervous. I don't like this very much, but I think it's an important theme. You can start, please. Or not? Maybe? No? Oh. I'm going to start to speak because we have not much time. I come from Lisbon, from Lapa, and I'm a GP trainee. And I'm going to take you all on a journey. Not really a journey, a little glimpse only, but on what we can do for the oral health of our patients. Can we start my slides? Yeah. No? Yeah. Yeah, okay. So, we are GP, we are not dentists, we are not, sorry for one question. This is appearing, not over here. I would like to.
It will go automatically.
No, but it's not over here. I would like to. Okay.
No, it's not here. It's there.
Okay, perfect. So this is the second or third slide, I don't know, but why this is important? It's important because there is oral cancer, and it's more frequent each day.
Mm-hmm. Yes, speak.
Thank you. That's a little hard. So, if we, as a GP, can look at the mouth of our patient that is accessible to us, we can detect in a early phase an oral cancer. But for that, we need to know the basics of oral anatomy and oral structures. We all know all of this, but there are some specificities that we should know, because we should know what's the normal mouth floor, what's the normal aspect of the lateral border of the tongue. We are not used to look at that. We also should know the name of the tooth. Should know that's a molar or a bicuspid, so we can refer it to our colleagues if it's needed. And what we can suppose that's normal when we see the mouth of our patients. It doesn't stink, it has gums that are pink, that have an orange peel texture, and the teeth are smooth and white, and don't bleed. The good part is that we don't need any kind of material. We already have all the material we need for the examination in our office. And it takes only 5 minutes if you are not accustomed to do that. So we should do this exam for all of our patients one at a time, but especially in the patients that are 40 years old, smokers, and drinkers, or if they have any complaints. To do this exam, we don't need only just to look. We have to look, we have to touch, we have to feel. We start by telling the patient to remove all the removable appliance. Then we look at the lips. We can look at the lips to see if there's any changing. We can start by the normal palpation of cervical and submandibular nodes. In the lips, we look and we touch. We put the finger, our hand in the lips, we raise them. We look by the inside of the lips, the mucosal, the teeth, the gingiva. And then we spread the chin to look at the buccal mucosa. Then we look at the posterior part of the mouth for the retromolar trigon. That's important. That's a lot of reason from there. And more important than that is to look at the floor of the mouth and the lateral and the ventral surface of the tongue. Lots of cancer develop there, and we are not usual to look at that. So we do this exam to identify, we hope, only benign lesions, like when you have candida, we can treat it. We have oral ptosis, you can treat it, and the patient becomes happier because he doesn't have any money to go to the dentist or the oral professional. But we also can identify premalignant lesions like leukoplasia, and then we have to refer it to the oral professional. We can only find tooth decay, oral cavities, and have to refer it. Okay, for this exam we have to see, we need to treat and to refer. Most important of all, we can diagnose in an early stage an oral cancer. Or a lichen planus. In the oral mucosa, it's more simple to diagnose than in the skin. For when we find these lesions, when we think they are benign and are caused by a fungal infection, we treat them with antifungal therapy, like we know. If in a particular case of anglocalitis, I've put this over here because it's better with the fusidic acid, okay? When you find another kind of benign lesions not caused by fungus, we can remove the possible cause and treat with a mouthwash with chlorhexidine for 15 days. If a benign lesion doesn't pass, refer to a neural specialist. So, we have to look, touch, and feel. Okay, put some gloves on. That's better. If it's benign, treat the benign. If it looks bad, just refer it to the specialist. That's easy and simple and fast. Okay. Sorry for the mess because it doesn't appear in it. Okay.
So now I'm going to invite up Jacopo Demurtas, and he's going to be presenting twice this morning. And the first presentation is titled An ICPC-based Educational Project.
Which one is yours? ICPC, first of all.
Okay.
There you go. So, there you go. Once you click it.
Okay. Once I click, wherever. Okay.
Yeah. Just click and then start.
Okay. No. Okay. Normal. Okay. Okay. Good morning, everybody. We are going to change to shift topic. We're going to speak about education and about a project we have of an ICPC-based educational project. We have a problem in Italy, which is that long ago we made the last job description of Italian family doctor. And it comes up with a group from SIMG, which was the Scientific Society for General Medicine. And when they plan this job description, they talk about the ICPC, International Classification of Primary Care, as a revolutionary procedure to change the way of making family medicine. Nobody has seriously considered to update this model. And so far, nobody has ever tried really to do so. Now we came up with this decision. We need a new job description because family medicine changed through time from '92. And we need a new job description which will encompass different fields of family medicine, considering also some aspects that may seem complementary to what we usually figure out as family medicine. But which are the possibilities to achieve this? Which are the way in which we can make this project possible? Perhaps we can try using this approach based on an international classification of primary care, and perhaps we may find a little help in using the Q codes, which map a different part of general practice and some complementary aspects. As you may have noticed, or you may know, ICPC usually is used to classify the clinical issues and processes through titles and chapters. But for contextual issues, we need something more, and a possibility to map things like continuity, accessibility, indoor pollution, research methods, is that one based on the Q codes. So our purpose was to produce an ICPC or Q codes based job description, on that to define a core curriculum, and to, if possible, educate on this new core curriculum. How? Well, first of all, we have to define a target, which may be the young family doctors. And then we'll have to find a way to expose them to some learning needs, to encode those learning needs in ICPC or Q codes, to gather evidence-based information for this project. And another interesting thing would be to work, as you may have seen sometimes in research, in couples, perhaps with somebody advising perhaps a Cochrane information specialist, which is the solution we are looking for in Italy. Evidence found will be the learning content, but also learning goal of this project. The learning goal will be the educational goal for the ICPC chapter, and ICPC learning goal will be divided in specific goals and those learning sub-goals. The best suitable educational strategy will be used to teach each different component of the objective with different timing for each object. So for cognitive, pragmatic, or affective issues, there will be a different methodology. For instance, you may be familiar with the environment of out of hours. During an OH shift, it may happen that a patient asks help for his pain in the eye. You have two different ways of thinking with this model. You can check in the ICPC, and so it's chapter F, component 1 for this ICPC2 classification, but you may also see it for a different point of view, and check it through the Q codes. So it will be chapter Z, and you can map in a different way, in the way we used for to map out of our service. So it will be QS2 in this case. So we're eager to find colleagues which are so eager them to help with this project. And we would like to ask whether you find it feasible and possible for our contest. Thank you.
Okay, so next up, I'd like to invite Anna Siqueira to the stage, and she's going to discuss the Gen Equipped project.
So good morning, everyone. My name is Ana Siqueira. I'm a GP resident in Ponte de Lima, Portugal, and I'm here to tell you a little bit about the Gen Equipped project. And why is that? Because many of the GPs feel uncomfortable with their knowledge in genetics, and also it is an important field in primary care. And therefore, an innovative project which is new and free, providing an online educational program was created. It was called the Gen Equipped project. And the main goal of this project is to providing an educational program in genetics for primary care, hoping to improve the knowledge and the better care of our patients with a genetic condition. The Gen Equipped project is formed of 9 modules on cancer, cardiovascular, prenatal care, and developmental delay genetic conditions. Also have some webinars, and there are some useful tools for daily practice. It's an European project with 6 partners involved: UK, Portugal, Iceland, Netherlands, Italy, and Czech Republic. So many of you may have already heard about it. And now we're going to browse a little bit on the platform. So you should type down primarycaregenetics.org and you enter the website. It's available in 6 languages as it involves 6 partners. In order for you to access the modules, you need to do a registration. It's very simple. It's all connected. You go then to the website, do the registration, and you will be able then to access the learning modules. And like I told you before, there are 4 main topics, like you can see here. And you just click on one and then start doing it. Also, besides the modules, you can find some webinars. You also need to type down your email for access. And then you can have, for instance, this one is on how to do a family history, how to proper take a family history. There are more. And the practical useful tools I told you were, for instance, on genetic testing. How are the hereditary patterns, and they're useful for your clinical practice. And the modules are based on real case stories. Sometimes it includes brief recordings of the consultation even. And all these modules have an evaluation. So first you do the pre-module quiz, then you do the program, the module, and you have a post-module quiz where you should get a grade of 80% or at least higher. And the good news is that these modules are accredited by the Royal College of General Practitioners and the European Accreditation Network. So it will look good on your resume. It's a certified course. And now again, we're going to look a bit more about the platform. This is how the module looks like. In this case, we have the genogram. It was, all the steps were there. You just follow the arrow. So it's very intuitive and user-friendly. This example is of the red flags. And another thing I'd like to point out here, for instance, you have a bold word, and here it's the explanation of this keyword because it was important. And another feature of the module is that you can also assess your own learning because it has some questions in the middle. And for instance, if you get a wrong answer, it will tell you why. And if it's a good one, it's okay, then you're fit. To conclude this presentation, I'd like to talk about the Portuguese experience. So a lot of events took place after the GenEquip project, and it culminated with the creation of a genetics group at our GP association in Portugal. And finally, I would like to thank Professor Heather Skirton. She's the leader of the project, and Professor Milena Panek, who's the Portuguese leader, for letting me be a little bit about part of this project. And here I leave my contact, and I'm available for questions at the end. And thank you very much for your time, your attention.
So now we have the last presentation of the 5, and I'm going to re-invite Jacopo Demurtas to talk about the Cisco's project. So please have some questions ready, because after this, we will invite all the speakers up to have a discussion.
One, two, three. Okay, it's me again. And I changed again subject. This is a startup project with the researcher in general practice, family medicine trainees. This was the Cisco's project. It was established in 2015 in Verona from Alberto Vaona, which is a Cochrane researcher, me and some other colleagues. And we tried to make something for different categories of health professionals. And there was a specific section for general practitioners. In the next slide, you'll see the homepage of this project. Here it is. So get into the Ciscomed. And there you may see, written in Italian, some of the aspects we want to explore. You'll see later in English, like now, maybe. Okay. These were the different buttons you may click on with documents, substitution, invoice service, educational project, research project, and so on. The first part, which would be the to give momentum to this project, was the opportunity as locum tenens, a certified opportunity as locum tenens. Then the certification, invoice system, and different aspects were of context. You can ask a colleague for help in Cisco's. Cisco's was having an educational program, research project, web app with different service. But we would like to focus on research and education. We have a button with different service for family medicine specialists or trainees wanting to dig in research. And so we made this page. I like particularly this phrase. You may find it also on the second. It is not the answer that enlightens, but the question from UNESCO. With those different situations, like submit your research project, participate to our project, as we have some ongoing projects, especially on the out-of-hours service. One is called the REACT project. It's a register out-of-hours access with an interesting referral rate to emergency service. And then we give access, a simple access to normal thing, but not all the family medicine trainee knew about it. It looked promising also to us, and more promising when we find a way to vehiculate, to sell somehow this possibility to do the local tenant service. It looked almost done, because it would be possible to keep this project alive with this particular service of a certified substitution, but then blank, end of transmission. Something went definitely wrong. And something went definitely wrong, I want to say to quote a title from the Journal of Clinical Oncology: failing to plan is planning to fail. We made several mistakes during our project and during our managing of this project. First of all, we thought we would play like entrepreneurs while we were just GPs. Second, maybe we give too much trust to some other operators. So we were with no proper business plan, thanks. Nobody paid for the service, as GP didn't pay for the possibility to have the certificate substitution service. There was no marketing, and suspicion from trades and from scientific association. The last hope for this project is in this web app I told briefly before, which is Casa della Salute Web, which could recover part of the service we would like to general practitioners and trainees to have. So I'm all ears, as we say in Italy, for your suggestion on this project. We spend a lot of time, and not only on this, and now we are just like this. We don't know if we are broken or not. We are much more like Schrödinger dishes or Schrödinger cat. Thanks again.
Okay, I'd like to invite back all the 4 speakers, please, to come and have a seat, and we'll have a discussion. So could you sit in the order that you spoke? So you first, you sit here. And then it was through the mouth, diaphragm. Yeah. See, is it possible to see your badges? Okay, so we're going to have a bit of a discussion just now. So just a quick reminder. So it was Carla Rodrigues who spoke first about HIV PrEP. And then João spoke about the oral health, which was through the mouth dies the fish. And then Ana Sequeira spoke about the Gen Equip project. And Jacopo spoke about the ICP-based educational project and the Cisco's project. So, any questions from the floor at all?
Thank you. I have a question for Jacopo. What the Cisco? What it is, because I didn't get anything of your presentation because I don't know what Cisco is. So I'm really happy to make a suggestion, but probably I will make it wrong. The last one, the Cisco. You talk about Cisco Med and.
Jacopo, come and stand over here.
Again. It was a sort of, let's say, educational startup. But you need something to promote this. So money should come from somewhere. And a way of finding something to keep this project alive was, as we thought, to solve the problem of lock-in tenants in Italy, which is particularly hardly felt. So it's like you have a lot of illegal substitution. Usually the trainees or family medicine especially not having a place of work, so working as lock-in tenants are or not paid or paid with points for the ranking or not equally paid, if you know what I mean. And these problems seem to be something to solve, and something also from the questionnaire we sent that general practitioners and so on, like pediatricians, would pay for the solution of, okay? So it looked like something to keep all the other parts, the research part, the educational projects alive. Yet, when we were ready for this part, so the system was set, and we have all the parts, the GP trainees registered and certificate, nobody paid for the service. We just sold, I say we, but it's not we, it was the entrepreneurial real part. When we try to give this service and so to get something back to, when we try to sell this service and we see that there was no response, even from those who told us that they would have bought these, where we say, okay, we are here almost like volunteers. We spend a lot of time and a lot of money on this. Maybe we have to figure it out differently. Maybe this kind of, sorry, I finished just this. This kind of service needs to be for free in Italy, even though they say they would have paid for it, okay? And then from that, you would start with all the other buttons. Thanks.
I'm aware that we started late, and I'm aware that people might be hungry for lunch, so we're going to shorten the question session a bit. What I thought we will do is we'll bring up people individually rather than having a group discussion. So I'm going to ask Carla to stand up and come over here. So, yep, so Carla spoke about HIV PrEP. I've got a question for Carla. I would like to know about, is there any maximum time period for which PrEP can be prescribed? Is there a maximum period of time? So, for example, yeah.
You mean how long before risk-taking?
Yeah, so I was just wondering when you, I don't think this is working. Okay, so I was just wondering with regards to PrEP, is there a maximum period of time which you can take it for or not?
Your whole life. PrEP is the same thing as Truvada. Have you heard of Truvada? Truvada is one of the antiretroviral pills that you give after infection. But they realized that if you give Truvada before the risk-taking behavior or the risk action that will give you HIV, Truvada will have a protective effect. So we have patients taking Truvada their whole lives. So the safety profile of the drug is widely studied.
Any questions for Carla?
Thank you for your presentation. You spoke about the risk of resistance at the start of the treatment, but how is about this risk for long-term effects?
The risk of resistance of after you get infection, right?
No. The risk of resistance for long-term use of PrEP.
There is none. The thing is, if you start PrEP with on the period of zero conversion, what can happen is that your HIV virus might not respond to it. So you will have to shift to a different antiretroviral pill. But then we are not talking about PrEP, because it wasn't given before infection. It was given after. The thing is, most studies that evaluated the efficacy of PrEP, they said that, okay, we protected 86% of people taking PrEP. But maybe those 14% were on zero conversion period. And that's why they didn't got protected, okay? That's the thing. We need to check for that window and give a blood test, wait a bit, and that's not well defined yet. Each service has its own protocol. Then repeat the test. If it's negative, you can give PrEP. If it's positive, you will treat it as an HIV infection. That's the only difference.
Hi, thank you for your presentation. For men who have sex with men who think that they may forget to take the odd tablet and don't think that they can plan around their sexual activity, what would you recommend?
Daily.
Daily.
Yes.
And if they forget?
Yes.
What would happen?
Probably nothing will happen, because in men, the drug will accumulate on the tissue. Okay, but in women it's worse, because the accumulation on the tissue, it takes longer to achieve. That's why women should take daily, and probably, depending on the risk-taking behavior, men can take it before and after. But I would recommend, the thing is, we should think of PrEP as a prevention measure. The same way we talk about our patients that you should work out, you should eat properly. So it takes action from us as well. We can't just prescribe it and wait for it to happen. Okay, we need to educate them not only on taking the pill, but also on preventing themselves from HIV and from STIs and so on. So it takes patient education. And actually now we are not even having doctor education on PrEP. So there's still a lot to do on this subject.
I really enjoyed your presentation, and I just wanted to give a quick comment, which is I personally feel as a GP, I would be very nervous to prescribe PrEP, particularly with a lack of knowledge of drug interactions. But I'm very happy to be aware of the service and who to refer patients to, and I think that's really important.
Of course, for example, if you take USA, GPs can prescribe PrEP. Okay, they have the guidelines from the CDC, and they tell them exactly which patients are eligible for PrEP. But in Portugal, the thing is not so clear, and the norm that came out 2 months ago is still not so clear. In Portugal, we refer the patient so that the infectious service will prescribe PrEP. In Belgium, it's the same. The GP can prescribe, but the drug is not fully paid if it's prescribed by the GP. So they refer to the infectious service, and then if they prescribe, the drug will cost 30 euros per month. Come on.
Okay, thank you very much, Carla. Have a seat. I'm going to ask João to come. And so João spoke about dental issues, oral health. Any questions for João, please? Come on. Let's have a question from the audience. No? Okay. One of my concerns as a GP is quite often patients will come to us and they want antibiotics for a dental abscess. Yeah. But in the back of my mind, I'm aware that our medical insurance, our medical defence, doesn't cover us for dental problems.
Yes.
So that would make me nervous about taking on more for dental problems, when really that should be the dentist's issue, not ours.
Okay. Here in Portugal, it's a little different. I don't think the insurance specifies that. We are talking about the insurance of the medic.
Yes.
Okay, it's a little different. But nevertheless, I think we, as GP, we should be able to help our patients. And in Portugal, we have lots of problem of accessibility to the patients to the oral specialties. They are paid or they are so I don't know how to say, they are overwhelmed in the hospitals. So there are lots of patients that are it's not affordable for them to have oral treatments. We cannot treat, we don't have that specification, but there are important lesions we can diagnose. Some of those we all treat, candida, we are always treating that. In that specific case of dental abscess, we may be able to identify. We have a little program in Portugal that we can refer it to the dentist in the medical primary care. It takes a little long, but we are able to do that. And prescribing antibiotics, we should have, as a GP, a little bit of formation because there are some specifications about the dental abscess. We prescribe the wrong antibiotics, and we gave sometimes Haynes anti-inflammatories. That's not the right thing to do. So going back, I think we need some formation from our part and a better integration with our colleagues. But we don't have that problem about the insurance.
Any other questions? Okay, Susanna?
Hello, I'm Susanna, and I was talking with Beatriz because there is some difference between the north and the south.
Yeah.
And I'm a little bit concerned because I didn't know it. Here in the north, we have a special program for the oral, it's like the program for the intervention in oral cancer.
Yeah.
PIPCO.
PIPCO, yeah.
Yes. And we can give a voucher to our patients, and they go to specialization clinics to get the treatment and diagnose and treatment.
Yeah.
But I just realized that in Lisbon, for example, you don't have it.
No, it's nationwide, okay? But supposedly we, as GP, should identify some lesion, or the patient should communicate that lesion to us, and then we would activate that kind of PIPCO, okay? So there are some kind of lesions that we can all treat. We see, diagnose, treat. The other ones we can refer. That PIPCO system, it's what I put in the refer to the specialist. That's a group of dentists or stomatologists that do that kind of diagnosis. Okay, but that's nationwide. But first we have to suspect of anything, so we have to look. Okay, and there's lots and lots and lots of patients that we don't know what's going on. The oral cancer takes a little long to develop, and we have not established an early diagnosis of it. So we have to complement that PIPCO. Okay. Okay.
Okay, I'm now going to invite up Anna for some questions. So she spoke of the Gen Equip project. I'd like to ask you, Anna, what was your involvement in the project?
Well, my involvement in the project was after the project started in 2014 and ended in August 2017, so last year. I only entered in the later phase of the project when there was a workshop in London with all the European partners. So I only took part of it then. That was a big event with everybody. Then in each country of the partners, several workshops took place. I can only answer for the Portuguese ones that I attended. And the purpose of these Portuguese workshops were to discuss the project and what are the concerns of GPs regarding genetics with the GP Association, with also nurses and other doctors in Portugal. And then this culminated with the creation of a study group in genetics, which I and 3 more other colleagues started. So we're hoping now to give continuity to this
I think it's really useful because I know, certainly from a personal perspective, there's lots of knowledge gaps in that area, so it's very useful. Has anybody got any questions from the floor for Anna? Okay, well, I've got another quick question, which is just about the pregnancy module. What does that involve?
Prenatal care, for instance, genetic risk counseling, and what are the red flags and how to advise couples that want to have babies. So
great.
Yeah.
Okay. Thanks very much, Anna.
Okay, thank you.
Okay, I'm now going to invite up Jacopo. So just to remind you again, he had the 2 projects, the ICPC and Cisco's. Any final questions for Jacopo?
You.
I would say complementary information.
Okay.
It's a good idea to take ICPC as a basis. Oh, I'm sorry, I'm Marques. I am a member of the Wonka International Classification Committee who is developing ICPC. And ICPC is just a little bit outdated because it's up to 98, last edition. And we are working on ICPC 3, and will be ready in 2 years, I think so. So it could be interesting to take the general draft of ICPC 3 if you are willing to develop quality-based instrument. It's only that, okay? And we would be more than happy in our group to receive more people and young people and women, because we are a group of men, very old, and we are dealing with the tool you need to make research. So we need young researchers to help us from whatsoever country. And the next meeting will be in Ukraine, in Lviv, at the end of August. Okay?
Are you planning on using the Q codes for audit and research purposes?
Yes. Yes. This is
Okay.
brief.
Anything?
Yes.
What were the lessons learned after the failure of the Cisco's project?
And there in this not finding fundings for keeping the project going on. So in the final cause of failure is this, we can't spend of our own to keep this project on. We have to adapt to the situation and to find a different way to move on with the peculiarities, the characteristic of the project, withdrawing from that kind of platform. Okay.
Okay. Oh, one final question from Chloe.
I just wanted to ask you, why do you want to do it nationally and not internationally? Because I think we need a European core curriculum and not just, we need to stop working little by little, we're stronger together. Yeah. So why not thinking like more international?
We can do it, or we can try to. Okay? If you think it's interesting also for other countries, we can share it. I think the ideas may be common. I don't know if other countries have the same problem with the substitutions and the locum tenens stuff. So in your country you have problems to substitute a general practitioner, or there is no possibility of this kind of shift in primary care service? It's a question. Yes, you started.
Okay, so that wraps up our session of rather eclectic presentations. So thank you all for coming, and if we could all thank the speakers in the usual way, please.